Over to my presentation at this point in time, and we'll go ahead and get the party started in that regard. And as I said, my talk this evening is on CRRT, and what is it and why should we use it more? I think we should use it more, especially on very critical patients. It's really intended originally to be an ICU tool. That's kind of how it started. It actually started with nephrology, but it has since sort of morphed away from them, and there's a lot of controversy surrounding it. I am a true believer, however. First thing I want to talk about is what are these various therapies? Because we're going to talk about CRRT and how it relates to dialysis, but really we're talking about intermittent therapies versus continuous therapies. So on the intermittent side, which you see right here, is peritoneal dialysis, hemodialysis, SLED, which is slow, low efficiency, or sustained low efficiency, either one, dialysis. And it was basically companies who didn't have true CRRT's way of trying to mimic it by doing these long, low efficiency dialysis runs, but it truly is not the same. I'm going to explain to you why and go through that. And any of these various things. And on the continuous side, you have peritoneal dialysis, which I don't know why that's on there, it really shouldn't be, but CRRT, ultrafiltration, hemofiltration, hemodialysis, and with CVVHD, which is continuous hemodialysis, and hemodiafiltration, CVVHADF. And we're not going to really spend much time talking about plasma absorption and MARS and stuff like that, which is more for liver and other inflammatory mediators. But we're going to talk a little bit more about specifically these things here in this section. That's what we're really here to talk about today. And let's see, my thing is locked up here. Oh, there it goes. Okay, so to do dialysis in the ICU that is continuous, you want to, first of all, choose the right thing, because you can do intermittent dialysis in many circumstances. CRRT is not for everybody. You want to individualize the therapy to the patient. If the patient is very, very, very hypotensive, then you put them on intermittent dialysis and you will find that they become even more hemodynamically unstable. Generally, you have to stop the intermittent dialysis run, and basically the patient does not get treated. If you have a patient who has a closed head injury, for example, and you put that patient on hemodialysis, you can develop dialysis disequilibrium syndrome, or DDS, and you can even further exacerbate an already elevated intracranial hypertensive situation. And it can result in some pretty bad things happening, including mortality. Patients who are extremely sensitive to volume status and their requirements, when you try doing intermittent, again, you're doing it over a very brief period of time, and that can result in some real problems in terms of hemodynamic instability. You want to make sure you do it well and efficiently and safely. You want to ensure good metabolic control, ensure adequate dosing, minimize the downtime of the therapy, and ensure good volume control. Volume overload is evil. And I'm going to say that twice. I'm going to actually add that in this next slide. CVVH and ECMO is really interesting because you can integrate it directly into the circuit. And it's very beneficial, which I'll show you, in maintaining homeostasis, acid-base balance. It removes lactate, fluid management and balance, electrolyte disturbances it can correct, but it does it over a longer period of time. It doesn't have to be done in a 2, 3, or 4 hour period, as is the case with traditional intermittent hemodialysis. And again, I said it, I was going to say it twice, ensure good volume control. Volume overload is evil. We have all, at one time or another, seen this patient. And this patient is severely, grossly fluid overloaded. In fact, the upper portion of her eyelids appear to be water balloons. This is not an uncommon appearance. And, this is clearly anasarca at its finest. And there's a saying, and I can't give the person credit who said this, but somebody had taught me this saying, that anasarca is not simply a visually displeasing problem. That if you look like that on the outside, all of your end organs also look like that. And that's something that you have to consider. The heart, the lungs, the liver, the pancreas, the kidneys, everything. So you wonder why patients that are this massively fluid overloaded go into a multi-organ system failure. It's not a hard thing to imagine that the perfusion to the tissue of the organ, the end organs, is going to be compromised with essentially what becomes a global compartment syndrome, if you will. So there's a variety of machines out there. This happens to be a type of machine that I personally like. It's one that I have a lot of experience with. It has some distinct advantages and it has some disadvantages. I'm going to talk about both. So anyway, who makes this is Baxter Gambro, and it's called the Prismaflex, and it is a gravimetric device. And what that means is that each of those bags that you see down here are on scales. So you have replacement fluid bags here, and you have an effluent or waste bag here. And these are 5-liter bags. And all of these measurements, all of these weights have to be equal, so that if you're adding X amount from one bag and you want it to be zero balance, well, that amount had better be over in this bag by weight, or the system is going to alarm. So I see that as an advantage, but again, if you bump it, that makes it alarm and shut off, and you have to reset it. If the scales go bad, it's going to be a problem, of course. That's something you need to recalibrate them. You're changing bags. The physical, the labor intensiveness of this particular device is much higher than another one that I'm going to show you. But regardless of that, what I'm trying to convey in this slide is you can have a brilliant machine, but if the person running it is like the clinician that you see on the right, then it doesn't matter how brilliant the machine is. You have to program it properly. If you have garbage in, you're going to have garbage out, is I guess what my message is. Here is another device. This is made by NextStage, and you can see that it has a little bit different design. It is a volumetric system. It can hold up to 5-liter bags here. It hangs like on an IV pole, not necessarily on a desktop, but you can see it's pretty small footprint on this compared to the other one. Originally was designed as a home dialysis unit, actually, and then modified to be a CRRT machine. It will do everything the other does, but this is volumetric. So, meaning that basically each pump has a stroke volume, and it counts the number of RPMs, and it calculates the volume from that regard. Another potential advantage, which could also be a disadvantage, is that you put the waste into a sink, and so you don't have to change the waste bags all of the time. So it decreases the labor intensivity of it. However, you also have to consider, is it accurate? Now, I've had some people tell me, some nephrologists who are very, very strong CRRT users, that studies that they've done have shown that the volumetric was equal to and maybe even more accurate than the gravimetric, but I'm not really sure about that. Regardless, I wanted to point out that there are different technologies, not one technology exists, and each of them have advantages and disadvantages. You have to decide what's going to be best for you. The other thing, too, is that the NextStage machine, I will say, does not integrate into the ECMO as easily. It can be done. but it takes a little finagling. The Baxter Gambro Prismaflex machine does integrate in much more easily, and in that regard, I do think that it, at this point, is the better machine. CRRT is, in fact, an alphabet soup. You have SCUF, CVVH, CVVHD, CVVHDF, MUF, where does it end? You know, it's hard to say, but let's talk about these different therapeutic modalities. Well, we're all familiar with diffusion, right? Hemodialysis essentially relies on diffusion. I'm not going to go over the slide. We all know what high concentration and low concentration is and how that all works. So I'm just going to skip that. But I am going to say that when you do continuous dialysis with a CRRT machine, that you will have both diffusive clearance and some level of adsorption. So some of the inflammatory mediators that are too big to cross over will stick to the fiber bundle and eventually clog it up if it's high enough. So it's one of the things that you can do when you have a patient who is in fulminating CIRRs. You can put them on a device. You'll frequently have to make changes to the filter if they have very, very high inflammatory mediator load. And of course, you're gonna do some ultrafiltration with it so you can remove volume from that as well. Let's see. And okay, so CVVHD, which I think, frankly, makes no sense whatsoever, but some people do use it. I wanna bring it up. It's continuous veno-veno hemodialysis. It relies only on diffusion. It's for fluid removal, small solute removal molecules. It does have countercurrent flow, diffusive, and backfiltration, and you can, of course, ultrafiltrate with it. But this is essentially no better than dialysis in that regard. So then there's SCUF, basically the same as MUF. It's just essentially the same thing as us cutting a hemoconcentrator into our perfusion circuit, and it is just for fluid removal, nothing else. Keep in mind, something that people don't get very often, they don't figure this out that well, is that the fluid of the effluent is isoosmotic. So that if the potassium of the blood plasma is 4, the potassium of it will be 4, the effluent. You cannot affect any electrolyte when the fluid removed is isoosmotic. Something that people forget about, and they think, oh, well, I'm affecting something, but you're not. You're doing nothing. All you're doing is concentrating the fluid compartment and nothing else. But what does that all mean to us? Well, you look at dialysis. Dialysis essentially removes what you see there. If you look at the top part of this right here, little, very small molecules, and then as the molecules get larger and larger, well, dialysis diffusive clearance cannot clear it. So by the time you get to myoglobin, actually under myoglobin, at 17,000 Daltons, dialysis absolutely cannot clear that. But when you look at what the kidney normally does, you can see that its ability to remove molecules is they can remove much, much, much larger molecules. So all of this area that you see here in the blue essentially is an opportunity, but it's also an opportunity for a better technology, which we're here to discuss. But it also, if you look at inflammatory mediators, they generally live in the 17, 20, 25, 30, 35,000 Dalton range. Now, there's some that are much, much larger than that, and they need to be removed with adsorption therapy as opposed to maybe even plasma adsorption therapy, but that's another topic for another day. Right now, we're going to talk about those pro-inflammatory mediators that can be removed. Now, I'll also say the anti-inflammatory mediators will be removed also. It's something that you need to take into consideration. For every yin, there's a yang. But if you have a grossly elevated level of pro-inflammatory mediators and a depressed level of anti-inflammatory mediators, and you're removing a block of volume containing both, you are disproportionately clearing the pro-inflammatory mediators at a greater level until you can get it reduced to a point where the anti-inflammatory mediator process can start to balance the patient out with its own natural homeostasis. So this is what convection looks like. You have blood going in, you have the little pipe, little straw fibers of essentially a hemoconcentrator, and then blood coming back out to the patient, and you have a very high pressure on the blood phase. You have pores in the straws, in the fibers, of 50,000 Daltons. So what that's going to do is generate a pressure that is going to push the plasma water through the pores of the fibers to the waist and then out. So instead of a concentration gradient, as you can see, it is a pressure gradient. Very different. It's not that you create a negative pressure on one side and want to suck it through. You actually want the pressure on the blood side to push the ultrafiltrated plasma water through the pores of the fiber. That's how it's intended to work. And there is a pump on these machines for the effluent, which is actually used as a dam to control the speed in which you're removing the fluid, as opposed to something that sucks it across. So when you look at CVVH, which is my personal favorite therapeutic modality, it is used for fluid removal, fluid replacement, solute clearance, convective clearance, and a minor amount of diffusion. So you see the difference there, very minor amount of diffusion. But you see the red access coming in and then the blue going out back to the return. And this is something else. In perfusion world, red is always left.
Yeah.
In the dialysis world, it's opposite. Access is red as opposed to, in our world, red return. So keep that in mind. When you're looking at a dialysis catheter, the red is the access, the blue is the return. And that's because it's been concentrated, and that's how they distinguish those colors. But it's exactly opposite of what we're used to. And then you see the replacement, and the replacement in the magenta can be pre, but it can also be post down here. And then you have the effluent. And what's important about that, I'm sorry, let me go back. What's important, I'm sorry. I'm moving the mouse on my screen like a dummy and not on this one. So I'm pointing to something on my computer and you all don't see that. Okay, I'm sorry. That was my mistake. So what's really important about this is that if you're returning it pre-filter, you're pre-diluting it before the blood is ultrafiltrated. But if you put the replacement post-filter, then you maximize your clearance. So what the trick with CVVH is to balance where this replacement goes. If you put it pre, because it dilutes it, you have less likelihood of clogging and clotting your filter. If you put it, but you reduce your clearance. If you put it post, you increase your clearance, but you have more hyper-concentrated blood by the time it gets to this point, and your filter life may not be quite as long. So something to take into consideration there. And I'm sorry about the mouse thing. I was using my mouse on the computer, and it's a different computer that's running the arrow, so I apologize for that. But you probably got the message. Here we have CVVHD. We talked about that already. I think it's pointless. I don't know why anybody does it. And then you have CVVHDF. And I believe the only thing that CVVHDF is actually good for is basically in using all of the pumps and fluids that are available in the circuit to increase the amount of therapy by milliliters per kilogram per hour. And I'll talk about how that works as we go forward, because you're using all of the pumps. I frankly think if CVVH isn't going to work, CVVHDF, I think you can get everything done with CVVH. But CVVHDF is a therapeutic modality that does exist, and you're going to have both diffusive clearance, convective clearance, and it takes both small and larger molecules. But of course, if you're using CVVH, if you're using convection, you are removing all of the small and large molecules. It's not differentiating and saying only taking the large one. It's taking them all. If it's in the plasma water, it's coming out. That's the way we're up to 50,000 Daltons, keeping that in mind, which albumin is higher than 50,000 Daltons, and therefore that's why you only remove plasma water, you don't remove plasma, right? We all know that already. So what is the rationale? Why do we do this? Well, CRRT became popular to try and overcome the shortcomings that exist with IHD that I talked about earlier. Fluid shifts, when they're done over a very short period of times, are very, very, very hard to do, and they're hard on the patient. In addition to that, we talked about the cranial hypertension, which can be a huge problem. So intermittent dialysis, even when done well, if the patient is unstable, in fact, sometimes they will say we cannot dialyze the patient's too sick to dialyze. That actually does happen because it can be very destabilized. But the ideal or artificial organ should mimic the native organ and restore homeostasis. CRRT is much more physiologic in that it is continuous. It's slow. It's over the course of a couple of days and even a week. So there's far less abrupt shifts. The ICU patients who are acutely ill, bed-bound, and intolerant of fluid and electrolyte swings that are associated with IHD are very good candidates for CRRT therapy. So let's look at some of these molecules. I told you albumin's at 55,000 to 66,000 Daltons. The middle molecules, and I want you to focus on down here, TNF alpha and C-reactive protein CRP that are both in the 25,000 Dalton range. So these middle molecules in this range contain a lot of pro-inflammatory mediators that intermittent dialysis simply cannot remove. Now, intermittent does great removing these, but we remove them too when you use, or you remove them also with convective therapy, probably a more appropriate way for me to say that. So the effectiveness of any artificial organ is based upon its ability to mimic the native organ. So let's go back and look at this slide again and include CVVH and convective clearance. Look at how much of that blue is now taken up from the CVVH. You can see that it's much closer. It's not the kidney. The kidney is the kidney. That's a special organ. But it certainly is a lot closer to it than what dialysis would lose. So the blue represents essentially the gap between dialysis and CVVH.
Can I interrupt and ask a question?
Yeah, please.
Why is that? Is it pore size, or how is it able to be?
Diffusive versus convective clearance.
Just those two differences.
If you're depending only on a concentration gradient, it's a great question. If you're depending solely on a concentration gradient, the pore size of a dialysis filter is 50,000 Daltons. It's exactly the same. But a concentration gradient can't force those larger molecules over. So it does very well with urea and creatinine and potassium or whatever else you want to pull across, smaller molecules. But when you start getting into the 25 and 30,000 Dalton range, you have to have a pressure gradient to push it across with that solvent drag that I talked about. Okay. That's a very good question, though. I appreciate it. So here is a basic circuit that you can look at. So you can see, again, the axis is red, and you can have a pre-blood pump, which you frequently use if you want to do citrate protocol, which regionally anticoagulates versus systemic anticoagulation, but I'm going to talk a little bit more about that as we go forward. You've got the blood pump coming down, and then here you have the return going back up to the patient. You can have post-filter replacement. I talked about how important that is for clearance. You have your effluent here coming down. You have dialysate going through. You have pre-filter replacement here. So this is an example of CVVHDF in essence. It's everything. If it's just CVVH, then you have a post, or you have either a pre or post filter replacement on one particular pump, or it could be two. You can actually run it 50-50 and have 50% of it pre, 50% of it post, and your effluent, but you don't use the dialysate and you don't use the pre-blood pump unless you're using citrate protocol. We're going to talk about that again as we move forward. I really recommend that you learn more about this therapeutic modality. I think it's something that's very important. As I said earlier, I don't think very many perfusionists even know what this is, much less care what it is. But I really think we should, because this has real applicability for ECMO patients, and this has real applicability for us in the ICU. But it is not without its controversy. And there is a lot of controversy with this, all right? There are studies that show there is no benefit one over the other, CRRT versus intermittent dialysis. Studies, some of them, have not detected a difference yet. Now, why is that? Well, there are reasons. I'm going to talk about them. One of them, however, could be we just don't do it right, and we don't know how best to do it. Which patients may benefit, which ones may not, so specific patients and conditions. Timing of initiation. We talk about this all the time with ECMO. If you wait too long to put a patient on ECMO, the benefit of that ECMO is gone down and can actually get to zero, where it will no longer be of any benefit to put that patient on ECMO. When you have a patient who has acute kidney injury or massive fluid overload and leaning that direction, the longer you wait, the worse everything seems to get. So timing of initiation is hugely important. Technical issues, of course, play a role. Regimens, what's the dose? What's your fluid management? And dose is measured in CRRT with effluent dose, and I'll kind of explain that as we move forward here. Concurrent care also, dosing of antibiotics and nutrition. Remember I told you, you remove not just the inflammatory, pro-inflammatory mediators, you remove the anti-inflammatory mediators too. So, and also you remove antibiotics and you remove nutrition. So you have to compensate for that as you use this therapeutic modality. Well, if your program looks like this, and I won't go through all of everything, you can read it yourselves, but if your program looks like this, you're not going to have a CRRT program. And this is not uncommon. And it's a big problem because it makes the therapy look like it is non-beneficial in the studies, and that really matters. When you do it well, the difference is remarkable. And look, I'll tell you that anecdotally, I realize this is not, I have never done my own randomized controlled double-blind study to explore CRRT, but I've got a pretty good amount of anecdotal experience with this device and with this therapy. And it has saved, no questions, I have saved patients' lives by being able to offer this as an option for them in hospitals that didn't have it. We could talk more about those grand stories. We all love them in our business. It's what makes us want to do what we do when we actually help people. But I've got a lot of stories, and they're good ones, and I've seen it make a huge difference. And it has a lot of utility. This basically just essentially represents the same thing that we talked about. Is if your prescription says you want 25 mLs per kilo per hour removed, but you're only removing 16, then you're really not providing the dose that you expected to, and that patient is not benefiting from it. And that can be for a whole variety of reasons. Generally, they're technical reasons, and it has to do with the access, and we'll talk more about access. But there is a paper that was done by Dr. Ronco, who really, I think, is considered the father of modern CRRT. It was published in The Lancet. It was on survival and dosing. And if you look at group 1, it's 20 mLs per kilo. If you look at group 2, it's 35, and group 3 was 45. Though not statistically significant, group 3 did have the highest improvement, but group 2 definitely did, and that's at about 35 mLs per kilo per hour. And that's how much effluent is being removed. Now you're replacing it with the replacement fluid, but it's just how they do it in the nephrology world. It's very different than us, but the dose is actually your effluent dose. That's what it's measuring. But if you need it to be zero balance, then your replacement is going to be exactly equal to that. If you want to remove fluid from the patient, for example, then what you're going to do is you're going to have a patient fluid removal. So you may be giving back 3,000, but removing 3,200, which means you're taking 200 off for that hour. So your effluent dose is still going to be considered that 3,200, not 3,000. So there are studies, and what it shows us is that there is a break point where basically it's dose dependent. So if you look at the scale, you have improvement in survival up to a certain point. And then it really doesn't matter how much you do, what your dose is. You could be 65 mLs per kilo per hour, and it's not going to make any difference. But this area here at this break point tends to be a practice-dependent region. And some people feel it should be here, and some people feel it should be here. But from the data, there's no improvement in survival once you reach some point. The question is, we don't really know what that point is. And I think that's something that's just never been well defined. So keys to success when you do this in the ICU is you want access, 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 access. And then you have the circuit and the filter and the membrane. You have to have those things. You have a blood pump, you have a filter, and you have vascular access. If your access is bad, forget it. It's just simply not going to work. Failure is almost always secondary to the filter clotting off, but it's not always due to insufficient anticoagulation. Blood flow and other circuit factors have equal or greater importance. And generally speaking, when you have the catheter bent or kinked or it's stuck up against the wall, these catheters, I'm going to talk about dialysis catheters, these temporary dialysis catheters, they're horribly, horribly fickle. That really, you've dealt with it before. I'm assuming you've had that experience in the ICU with the dialysis catheter not working with the ECMO patient.
Generally, we're hooking it into our ECMO circuit.
Do you have much experience with the temporary dialysis catheters?
Really, no.
Not too much? Okay. So basically, these are the various ones that are out there. I don't want to spend too much time on these, but they come in different lengths and different configurations. But basically, they're double lumen tube, and they can be anywhere from 13 to 16 French and from 19 centimeters to 50 centimeters. And that's the tunnel. The temporary is 12.5 to 24, 11.5 to 14 French. And bigger is better. Okay, I'm just going to tell you right now, the bigger is better. All right, fellas? And this is by far the best place to put it. If you put it in the right IJ, it is a straight shot, straight down into the right atrium at the SVC RA junction, which is where you really want it to be. That's going to give you the best flow characteristics for this device. If you're using the femoral catheter, you need to use the long one, but no one likes putting anything in the groin, okay? I mean, it's got infection problems, you can't bend the patient, they tend to get kinked, but sometimes that's where they put them and they go in there frequently. If here's a formula, you can take a look at this, but if you're going in the right IJ, you take the height divided by 10. 90% of those patients will have the central lumen right where exactly it needs to be. If you're putting it in the left IJ, you need to take the height divided by 10, and that's in centimeters, by the way, plus add 4 centimeters. 94% of the time, you're going to be in the right spot, right subclavian, left subclavian. So there's a little formula there. You can copy that down, write it down, or whatever you may want to do with that. And then primary factors affecting access. If your access is great or bad, your blood flow rate's going to be affected, your treatment time is going to be affected, and your blood recirculation is going to be affected. In fact, let's talk about blood recirculation, because sometimes you're in the ICU, you have one of these catheters in, and you are trying to, go ahead and put that, leave that image up so we can go over that image, thanks. But you'll reverse them. You'll make the access blue and the return red. Well, you can easily see what's going to happen. Even with the access red and the return blue, you're going to have some blood come back this way. But if you have to reverse it to keep it running and you're accessing from here and returning here, whoa, it's just gonna whoop and switch right back in there like that. So you do it to keep it running. You have to compensate for it. Your recirculation like this is probably bordering on, I would say, 20%. If you reverse it and you're accessing blue and returning red, I would say your recirculation, I would reckon to guess, is going to be pretty close to 40%, I would think. I'm not positive about that, but that's my thought. But you'll obviously decrease your clearance and you'll increase the potential for clotting with your CRRT circuit. Summary of access recommendations: larger is better, right IJ, right IJ, right IJ, even though that says right IJ, left IJ, femorals and subclavian. My view, right IJ, right IJ, right IJ, it gives you the least amount of problems. Use appropriate sized catheters and place tips at appropriate locations. These things, these access catheters, temporary dialysis catheters, are meant to be buried to the hub. If you leave part of it out, it will have a tendency to kink, and once it kinks, you're done. The catheter is done. You're going to be putting a wire in there and they're going to be switching it out. You want it buried to the hub in order for it to last as long as possible. Of course, all of this is solved if you just hook it into the ECMO circuit, but if you are involved in the ICU and you are using this on patients, or you're consulting or whatever it may be, providing the service. We provide the service. We actually provide a CRRT service. I think we do it better than anybody else does. But with that said, if you look at this graph here, essentially what it shows you is the replacement fluid flow to the blood flow and the different patient sizes. And if you look at the blood flow, as the blood flow increases, you can see, that your replacement fluid rates are going to be stable, are going to decrease. But as you slow down, you can see how that's going to affect that. So you need to have good blood flow in order to achieve the kind of fluid replacement rates that you want. If you don't have good blood flow, then this is just not going to work. So citrate, I talked about that. I think it's tremendously advantageous. You can put the citrate in the pre-blood pump and run it, and you essentially chelate all the calcium that is going through the CRRT machine. So if you had a patient, for example, who needed this, and I've thought about this with ECMO if there was a way to do it, but I think the flows are just way too high to be able to do it. But it'd be pretty cool if you could, where you could regionally anticoagulate just the ECMO pump.
Yeah,
that was
the circuit.
Possible. That would be really something. But I think at 4 or 5 liters of flow compared to 300 or 400, 200 to 400 cc's of blood flow is vastly different. But it's really good. But you can basically chelate all the calcium, and then you have a central line where you replace the calcium in the patient. And it gives you the formula there on how to do it. And it's very helpful. What you can't do is make the mistake of putting the calcium into the same dialysis catheter and having it get sucked back up, because then you clot your system off. Right. Or trying to give calcium in a peripheral vein. It's got to be in a central lane, right? We all know that. Now, keep in mind, this is not an approved technique, so it's off-label, but there's plenty of published protocols for this. They exist all over the place, and it's very beneficial, as I said.
If you could do that on an ECMO circuit, you could potentially do that on a heart-lung bypass circuit,
You could.
which would be scary.
Would be incredible, wouldn't it? No, it'd
Would be cool.
incredible. But think about the benefit of that to not,
sure.
well, but not on the heart-lung machine. ECMO maybe, not really on the heart-lung machine, because you have to be concerned about, blood that becomes, static,
Yeah,
that's
in the
not
heart.
flowing.
Yeah.
In the heart and everything else, and the coronaries, and so I think that'd be problematic to do that. For the pump, even with the ECMO, you've got that big long cannula. Sure, you're decalcifying and anticoagulating the blood pathway, but what would happen? What happens to the outside of those catheters? Those are some big tubes, and those big tubes, they're going to clot on the outside just as well. So I don't know. I don't know that it could be done, but it'd be interesting. It'd be nice. Because there's patients who are hypersensitive to heparin, of course, and if we could do that and not anticoagulate those patients, we might not have as many bleeding problems as we do. Because bleeding on ECMO is a huge problem, right?
Yeah.
So anyway, so the advantage. So here's the formula I was telling you about, and this is how you do it. Make sure that calcium goes into a central line, not into a peripheral line. Because if you infiltrate a peripheral line with calcium going in, we all know that causes, and it's pretty ugly. If you're going to use heparin, this is what we do for it. We basically run it essentially the same as an ECMO. The reason why we do that is because the flow is low. So with ECMO, you can get away, you think to yourself, God, ECMO is so much bigger, but you still only run 1.5 times the APTT. Yeah, but you're at 4 or 5 liters a minute. This is going sometimes at 200 cc's a minute, and the transit time through the filter is much longer. And it is. Look, you try to. All these things are somewhat reduced in thrombogenicity, but everything is thrombogenic. On all these foreign surfaces, you have to take that into consideration. These are various formulas. I've actually thought about wanting to use some of this for our prime on the pump. And I'll tell you why. If you look at, for example, let's look at the BGK425. That's 4 of potassium, 2.5 of calcium. And these are bicarb-based solutions. So they have a normal sodium level, but they're bicarb-based, which means you don't dilute, because, Normasol and Plasmolite, and certainly normal saline, but these are acetate-based fluids. So even though Normasol and Plasmolite are pH balanced, they have no bicarb. Mm-hmm. You will dilute your bicarb. You give enough fluid, you will become acidotic. So if you're doing, let's say you tried to do CVVH on pump, and you used Plasmolite as your replacement fluid, your bicarb level is going to continue to plummet. You're going to have to treat the bicarb. Then you're going to become hypernatremic, and you're going to have to treat the sodium. So these fluids, I wonder, well, they're more expensive. That's why we don't use them. Okay, for the general case, you really don't need it. But if you got a really sick patient, or when we do our systemic hyperkalemia, for example, I use this fluid for those cases. And I use this fluid for those cases because it is bicarb-based. And it's really, really, really nice. I mean, I have to tell you, there's a whole bunch of them out there. This is prismasate, but Braun has it. Next Stage has theirs. I mean, there's these bicarb-based solutions everywhere. And, they come in 5-liter bags. That's one of the other problems, is that you only want a 1-liter bag.
Right.
And, but that costs a lot of money for that packaging, and nobody wants to do it. But, the hospital can actually make this, believe it or not. There are hospitals that can make this stuff. Mm-hmm. It's not that hard. The pharmacists wouldn't like me for it very much. They get mad at me and stuff, but nevertheless. Oh, what's up? I can't see it.
Chat question.
Oh, chat question? Okay, I'll let me see. You want to go to the chat question? Okay, hold on, everybody. I'm going to go to the chat question. Hold on. Let's see. We have a chat question. Sarah, I have used calcium while on ECMO with a CRRT machine. Okay, how do you deal with pressure? Okay, let's see. We see it, Joe. Okay, how do you deal with pressures when hooking up to ECMO? Our line pressure kept low. Yes, absolutely. I have used calcium while on ECMO with CRRT machine using citrate. Well, if If you're on ECMO, you don't need citrate, so I wouldn't have done that, Sarah. But I'm going to get to these questions. I'm almost done actually with the talk, and then if we can, if you guys don't mind, it would be so appreciated to let me maybe use the little boys' room and then to come back. So we'll take a quick break after I finish the talk, and I'll address these questions because they're really, really good questions, and that way you get a cup. Okay, so because you want that cup. That cup's really important.
I want a cup.
You can't have one. You're disqualified. You're part of faculty. Faculty's excluded. Okay, so let's see. I got to go here, go here. Okay, look, it was my last slide. The key about all of this fluid balance and management is that it's all about making everything that goes in come out at the end of the day. We don't want our patients to be fluid overloaded. You saw that picture of that lady. She was probably a good 30 liters. That's 30 liters fluid overload. I don't think people really understand how much fluid you can hold. You know, not intravascularly. You're going to blow up, okay? The heart's going to just die.
Yeah.
But total body, how much fluid you can actually overload somebody. And if you've ever, and I wish I had the picture. You know, I hate it because my computer got stolen. You knew that, okay?
I knew about that.
I probably shouldn't have brought that up to you.
10 years.
Probably somewhat sensitive about that still. But my computer got stolen. I had a great picture on it of a patient that looked just like that lady that we had reopened the chest. And you could see the heart, and we ultrafiltrated that lady in the operating room, took off somewhere around 12 liters over the course of 6 hours, and her heart looked so much better. She looked so much better and was doing so much better. But then you get into the argument of albumin and not albumin. Should you use it? People are so recalcitrant not wanting to use albumin. I'm a big believer in it unless you have if you have a true capillary leak, then albumin would be the worst thing in the world to give somebody. I recognize that. But not every patient has a capillary leak, and it really makes a difference in terms of increasing the speed in which you can pull fluid from the interstitium back into the vascular space to be removed. But anyway, with that said, listen, I've finished the presentation part. I want to get to these questions. So we've got a couple of interesting questions, and you had said during the break that you wanted Timothy's question. Timothy, what is coming and when? So Patrick, if you want to address that one, that'd be great. And I got a text from somebody.
I think the future in general is pretty bright.
Okay.
There may be some political issues coming.
Timothy, we're not sure what you mean by that. And then Rebecca says, we see it, Joe. So that must have been my mouse that I was moving around, I believe. And someone also mentioned to me that I looked a little draggy and that I needed to perk it up some. So I'm going to try to do that for y'all too. How do you deal with pressures when hooking up to the ECMO? Are line pressures kept alarming the dialysis machine? Absolutely.
Yep.
And I'm going to tell you right now, you absolutely cannot. I don't care. I mean, okay, I won't say absolutely can't, but I'm going to say pretty close to absolutely cannot hook a traditional standard dialysis machine into an ECMO pump. They want you to, or ECMO circuit. They ask us to do it. You remember I won't say the name of the hospital, but they tried that how many times?
Yeah, it won't work. It will alarm over and over.
It just will not work. The environment, the pressure environment of the ECMO circuit is just too hostile. You have to remember, think about it. A dialysis machine is designed, and even these CRRT machines are designed for a central venous pressure. They're not designed for being in an ECMO circuit, so which is, you have pressures of negative, 150 on the venous side and positive 240 on the arterial side. So the pressures are enormous, and it can't handle it. So I would absolutely not true. Andrew from St. John's. Andrew, how are you, man? You were at the New Orleans conference. It's good to see you again. But I would absolutely just not try to do it, which means they're going to have to stick the patient. And if they stick the patient and mess up, now you got a hole in a vessel that, potentially is going to create a lot of problems for you because you're going to be anticoagulated. And especially if you hit the artery or something. And how you going to stick it in the neck and you accidentally hit the carotid. Now you got huge problems, and it happens. You don't want it to happen. Use ultrasound. It shouldn't happen, but it does. So even a needle stick in the carotid when you're on ECMO could be a real problem. I would recommend, Andrew, my suggestion is don't try hooking dialysis up to it. Try hooking instead the getting a CRRT machine. The next stage will work. You have to put a stopcock sometimes and sort of turn the stopcock a little bit. And if you do that, it won't see as much pressure, and it'll stop alarming. The Prismaflex machine from Baxter Gambro, look, I think all these companies are basically the same. I don't like any of them, frankly. I love the technology and I can't stand the damn companies. But regardless, I think that at this point, it's the best widget out there. I know that B. Braun used to have a machine, and that machine, they took it off the market. For whatever reason, I know that they have a new machine in Europe they're working on, but these companies, they're suing each other all the time. It's constantly a problem. And, the benefit to the patients and the advancement of technology is always stymied by these companies suing each other over one thing or another. And so hopefully we'll get more technology out there to use. But at the end of the day, I think that the Prismaflex machine is probably the best widget to use for our purposes at this point in time. And then I'll just quickly deal with this. Our solution was to use ECMO circuit to hemoconcentrator return to pre-existing SLIC in IG. Our solution was to use ECMO circuit to hemoconcentrator, right? Return to pre-existing SLIC in IJ. I'm not sure I know what that is. SLIC in IJ, unless he means IJ, not IG. Andrew, I can't quite figure that one out, man. Ask me that one again. So getting on to the Sarah's question, though, about the sheath in the IJ. Gotcha. Okay, must have been, yeah, you could do that. You can do that, and it works. But of course, you're going to then be dependent upon, using a clamp to remove fluid and then clamp it, or putting one of those little screw clamps on it and trying to adjust it. It works. I mean, I think you did the right thing because it worked. You needed it. But it's a very imprecise way of doing it. And it's 2018. We shouldn't be doing things like we did in the 1960s. I think we need to, I think I would, yep, it's finicky. Yeah, I would do that. Getting to Sarah's question, though, on the citrate, using calcium while on ECMO with a CRRT machine. I mean, if you're on heparin and you're anticoagulated, okay. Hey, can we just take one quick break? We're back on now.
Okay, great. So I meant to say citrate. I did not mean to say calcium.
Ah, okay. But you were heparinized, right?
We were not heparinized.
Oh. So you were...
So what happened was this patient was on ECMO for about 30 days already. Uh-huh. And we were having issues with bleeding in certain areas. And especially you could see it coming out of the intubation tube and things like that. So we knew that it was affecting his lungs.
Yeah.
So they did chest x-rays at least once a day, and they determined that the heparin was causing him issues with that. So they wanted to come up with something else in order to still use the CRRT machine and ECMO, but still be anticoagulated. Mm-hmm. So from the CRRT machine was running off of our ECMO circuit. Mm-hmm. And what we did is we put a citrate infusion pre-CRRT machine.
Right.
And then it went through, then the blood flow went through the CRRT machine. And I think I remember correctly that we put calcium back on the other side before it went back to the patient in order to maintain proper calcium concentration.
Yeah. Well,
and we didn't have any issues with clotting after that.
Yeah, you could probably do that because you were going into your ECMO circuit. In other words, you didn't have recirculation like you would if you were just doing it through an intermittent dialysis filter or catheter. So if you're just using an intermittent dialysis catheter, and you're returning it into that same catheter, and 20 to 30% of that is getting recirculated back, then you're adding calcium back to the blood as it's coming back, and that's going to create problems for you. But if you're going from your return into an ECMO circuit with a whole bunch more volume and no recirculation, and you're adding the citrate where you were, I can see where that would have worked. What I find interesting is that, and I know the flow is much lower. So you're telling me that before they started using the citrate, the CRRT was clotting off?
Yes, it had clotted off. I did a 12-hour shift, and it clotted off twice in just my shift alone.
Wow. Yeah,
so we were really having trouble with it, so we knew we had to do something, and so this was the first solution we came up with.
Well, I think it was a great solution. I mean, I'm not sure how the procedure, the case ended up, but I got to tell you, I mean, I think necessity is the mother of invention, right?
Yeah. So how much?
Of course.
How much citrate and how much calcium? What was your ratio there?
Gosh, I can't remember. I can find out if you guys want me to, and I can email you or something. But I can definitely get that information for you. But the guy, he was on ECMO even after we did that change. He was probably on ECMO for another month.
Wow.
And I was just there last week, and he is walking around.
Wow.
That's amazing.
Now that is amazing. It was
amazing.
That is amazing. You mind if I ask how old the patient was?
I believe he was in his 60s.
60s. And he was...
he was a younger guy, and he presented to the ER with like a really bad cold symptom.
Wow. Yeah.
It was very weird.
What did he end up what was his diagnosis besides ARDS?
His diagnosis was, I think it was one of those things where it was kind of like a mystery. That's why he was there for so long.
Wow.
Is that I know that some pulmonary issue, because his lungs were the main issue. They were completely whited out for weeks.
So he had normal cardiac function.
Yes.
So do you mind describing to us what your ECMO circuit cannulation setup was, and what circuits you used?
We use the Cardio Health.
Okay.
And we use the Avalon cannula, so which I think is pretty cool, because it's just one cannulation site with flow going in and out.
Right. We're going to be talking about that on Thursday.
Yeah, it's pretty cool. That's pretty much all they use at the hospital that I do ECMO at. Is the Avalon and Cardio Health. Gotcha. Yeah.
Yeah. So let me ask you this now. For the cardio help, my understanding is you are not supposed to cut anything into it to add anything like you did with the CRRT circuit. So was there any discussion about that, or was it just, well, this is what we have to do and this is just what we're going to do?
It's actually at the hospital that I do ECMO shifts at, they pretty much have at least one ECMO patient on at all times. They have a high volume of ECMO patients, and they have a protocol for CRRT machines with ECMO. So I don't know if they met with the Cardio Help reps and developed something or what, but when we set up our ECMO circuit before initiating ECMO, we already have stopcocks in place. Even if we don't use CRRT every time, there are stopcocks in place for when we do want to add it on.
Yeah, so that's a modification from what the system is actually supposed to look like.
It must be.
Yeah, and
yeah,
you know what?
Because I haven't seen it without it, so that's all I know.
And let me show you this. Hey, Austin, could you do me a favor? Could you run back into my office and there's that catheter. Grab that catheter. Let me show you something. I've got some, because on Thursday, we're actually going to be talking about ECMO and all the different various ECMO cannulation techniques that you can use, you know, and VA, VV, you know what? Yeah, that thing. Here, take a look at this. So I've got this catheter. So this probably, you know, reminds you of it. So this is what you're talking about.
Oh, it's an Avalon.
Yeah. So yeah, it's an Avalon. Okay, just see if you can see it.
Yep, there she is.
Yeah, there it is right there. Yeah.
Yep, there it is.
Yeah, here, I got to get
It's
my.
awesome.
You like that cannula?
If it's in the
They're
right
tough,
place,
though.
it's awesome.
Any issues?
Yeah, they're tough
Yeah.
though. They're tough. This is a 31. I got to tell you, I don't know that I want that
That's a
thing
big
stuck
one.
in. Yeah. I don't know that I want that thing stuck in my neck.
Yeah.
But you know, hey, look, the guy survived. But it is
Yeah, they all do.
It is a little fickle, you know, but I do think it's so much better than the dual cannulation that we use, and it keeps it
for
out
sure.
of the.
Like for infection and things like that.
Oh, absolutely. I mean, yeah, having femoral cannulation, it is horrible. We still do it, and we still do it. We're still seeing it. You know, we put one in the femoral vein and one in the right IJ. We try to use this more, but even with VA ECMO, of course, you know, you're going to be down there, and it really compromises what you can do with the patient, whether you can sit them up and, you know, all,
100%.
all that kind of stuff in the neck. And I hope you join us on Thursday, because one of the questions that I have, and Chris Loosby is going to join us on Thursday as well from Memorial, and they're like you, they have ECMO going all the time. And so there's always at least 2 or 3 patients on ECMO down at the med center. And but you know, I've talked to people who are saying that they're taking ECMO patients and waking them up and extubating them on VV ECMO. And I'm like, wait a minute. I mean, you might be doing that with a lung transplant patient, but I don't know. I mean, do you think that your patient that you just got through discussing at day 10 could have been, you know, on VV ECMO, could have been extubated? Or, I mean, I think these people are just too sick.
For this patient specifically, no. But of course, you know, it depends on the patient. It depends on the situation. Mm-hmm. But this patient, absolutely not.
Do you do that though? Do you wake patients up on ECMO? I know we're not talking about CRRT now, but we're talking about ECMO.
When she's done answering this question, I've got a story. It's pretty good.
Yeah. So do you have patients that you wake up like that?
We have. There's actually a patient that I walked in to start my shift. He was awake. He was a younger guy. He was probably in his 30s. And the nurse went up to him and said, you know, are you in any pain? And he could move his hand to do a thumbs up or thumbs down. And he did like thumbs up, like he was good. He wasn't in any pain or anything. It was pretty wild, but he was awake. But but still pretty sedated though. You know, they make sure that they're not uncomfortable.
But did you take the tube out? Did you extubate the patient?
The patient was not extubated. No.
Mm-hmm. Right. So, I mean, I'm hearing people are extubating these patients.
Yeah. One time years ago, I worked in Las Vegas, and we had a patient that was going to be transferred for a transplant, for a lung transplant, and he was on VenoVenous ECMO. He was extubated, and they knew he was going to be on ECMO for a good 6 weeks at least, so they got him up and walked him around the unit on a walker. And that was something to see 7 people like holding lines and making sure, because if he fell, he would have decannulated.
I would not be part of that.
It's the only time I've ever seen anything like that, and that was about 20 years ago.
That's unbelievable.
You think I'm making this up, but it's true.
And the patient did okay?
I don't know what happened to him. I mean, he was transferred out for a transplant eventually, so I don't
Yeah,
know.
but again, that's a lung transplant patient.
Yeah.
I think there's a big, and I think this is the issue. And of course, again, we're not on the we're off topic.
We'll get there on Thursday.
Whatever, we'll get there on Thursday. But I think there's an enormous difference between a patient who is infected and their white counts are grossly elevated, and they're acutely ill, versus someone who is chronically has pulmonary insufficiency, is on a lung transplant list, is otherwise okay. They're not infected. They're not septic. They're not sick. I don't know. I can tell you, if I was on ECMO for like this guy you were talking about, Sarah, that you guys did, don't wake me up. Do not wake me up. In fact, I'm going to tattoo that on my chest. Do not wake me up on ECMO. Just leave me alone. Let me get better and then take me off of the thing. But anyway, so that's it. So back to the CRRT though, sort of getting back on topic here for a little while. You know, I have these cases. I got called to a hospital. It was in a small town in Louisiana. And at the time, my wife was actually working at this hospital. And she talked to the medical director who had this patient in the ICU. And they had a gangrenous leg. And they had kind of whittled at it, but didn't, I guess, get it all. And they didn't cut. They did a BKA where they really needed to do an AKA. And anyway, this lady was really sick. I mean, her pH was 7.06. She was, I mean, just massively fluid overloaded. I mean, 30 plus liters. She was, I mean, this lady was dying. And I didn't have a CRRT machine. So I took 2 roller pumps from a closet and I just basically just made one with a hemoconcentrator. And I sat there all night long treating her with this and got her to where she was relatively normal. And then we just to make sure we fully disclose, the hospital had requested nephrology support from the local group in town, but they normally did not provide dialysis services at this hospital. It was a state hospital, of course, you know how that goes. And they said, no, they couldn't come transfer the patient to one of the other hospitals where we go. And the hospital attempted to get the lady transferred. And of course she was unresourced. She had no money. So none of the hospitals would take her. So all that was going to happen was she was going to just die. And so I did this all night long and parted to the next day. And then I was just exhausted. I mean, I needed to get some sleep and I needed to work too. I mean, I had a regular job. And so I went back the next day and she had gotten better, but then got sick again. And I did it again and I did it again and I did it again for like 5 days. And that lady they finally did the AKA, and that lady walked out of the hospital. She didn't walk. She got rolled out and she was a little bit ticked off that she lost her leg. I was kind of like taken aback by that. Okay, so she hopped out of the hospital. Okay, she didn't actually walk, but she survived the whole damn thing. And I mean, that's just one story of several stories that I have that are anecdotal in regards to how this therapeutic modality can really benefit patients. I think it's hugely beneficial. I think it's abused at times. I think it's misused at times, but I think that it has tremendous potential when used properly to be beneficial. The long and the short of the story, though, Sarah, if you're still on the line, and Patrick's sitting here, or anybody else that may be out there, is the nephrology group in the town was so mad at me for having done this that they reported me to the state board and charged me with practicing nephrology without a license. And by the time, you know, of course, I was working under the medical director of the hospital. So I was like, what the hell are you talking about? I'm just a technician doing the mechanical part. Anyway, by the time it got all the way down to them and I went down there and explained to them what happened, they were so appalled that the nephrologist wouldn't go take care of her, that they got their own investigation on them. I was like, that's justice there. Finally, something goes my way. You know, I got a pat on the back and they got their own investigation for refusing to take care of the patient because they were supposed to, you know, but they didn't want to because the patient didn't have any money. That's ridiculous.
Where did you cannulate for that? How'd that work?
Put a Maherker catheter in the femoral.
Okay.
Yeah, just put a femoral vein, you know, Maherker catheter in the femoral vein. And it worked. But it was not the time to try to be too complaining. Can you put an IJ in? Just put it in the femoral, whatever they're comfortable with. And again, it was a state hospital with very few resources. I mean, not even an idea of having a CRRT machine. I ended up buying CRRT machines, and that hospital eventually, although it eventually closed down because the then governor of Louisiana had a mission to close the charity hospital system down, which is sad because that was a staple of what was Louisiana. I mean, more training got done at charity hospitals. You saw, if you could see it, if there was a disease or an injury that you could see as a physician or a clinician or a perfusionist or whatever the heck you were, a charity hospital is where you needed to go because you saw it all. And but they eventually shut those down. But they eventually did get. That's how my CRRT machine service that I have actually began, was at that hospital, and they leased the machines from me, and I provided support, and the nurses ran it. I taught them how to do it, and they did a fantastic job, and it worked really well, and it was very beneficial to a lot of patients. So I think therapy is incredibly useful. It's slow, it's precise, you're replacing things, you're using convective clearance. In terms of managing fluid balance, in terms of managing electrolyte derangements, in terms of managing acid base, I don't think there's anything that works as well. Now, we do ultrafiltration on pump all the time, and we do that almost exclusively for fluid balance removal. But should we be considering using this more? Should we be doing some form of CVVH? If it removes those pro-inflammatory mediators, as soon as they do a sternotomy, we have some level of SIRS occurs. Should this become something we do routinely? I'd love to see it get studied, but I don't do studies, so somebody else would have to take that up and decide to do it. Sarah, I think you ought to do it.
Okay.
If you get started on that tomorrow, write the protocol, it'd be fantastic.
Yes, I will consider for sure doing that.
All righty, well, that's good. Well, do you have any other questions, Sarah, or anything else you'd like to contribute?
I think that's it for the CRRT.
Say that again?
I think that's all I have for the CRRT.
Okay, well, good. Well, what did you think of the program?
I thought it was good. I thought it covered a few things that I didn't really know the details of because we don't necessarily run the CRRT machine in the ICU. The nurses do, and then we run the ECMO machine. But when it's connected to our ECMO circuit, I think it's important to know all the details. So I really appreciate you going into depth about everything.
Sure, and I'll tell you this too. In fact, I'm going to type it in the comments. There's a akinet.org is one, and the other one is what is the name of that? Hold on, let me look this up. I think it's CRRT.com. I don't think that's what it is. I don't think it's CRRT.com. Let me see. No, that's not it. Google. Let me go to the Google. CRRT online. Maybe that's what it is. CRRTonline.com. Yeah, that's it. CRRT online. Let me put that on here. So there's two websites. One is akinet.org and the other one is CRRTonline.com. Both of these websites are excellent resources for anybody that really wants to understand CRRT. And there's several people, like I've mentioned Ronco's study, but there's the Australian group is huge in this. There's a Dr. Bolomo out there. He's done a tremendous amount of work on CRRT and its utility with certain patient populations. And also there's Dr. Kellum up at University of Pittsburgh, UPenn. He's real big. He's an intensivist up there. And there's a Dr. Luis Juncos at University of Mississippi in Jackson. He came from the Mayo Clinic actually before that. And he's done a tremendous amount of work on CRRT. And I think these, there's a lot, there's so much information out there, so much data out there. I really suggest we as clinicians look at it more as perfusionists, because I think that it's a tool in a tool chest that we can suggest and or implement for our really critically ill ECMO patients, for example, and maybe even translating this into the operating room. Maybe we need to consider insisting that we change our priming fluids, and maybe that would make some difference, or whatever it may be. I think that it's a tool normally not found in our toolbox, but somebody else's toolbox, that I think would be very beneficial for us as a part of the heart care team to be more knowledgeable of. I think we could do a lot better job with that.
So if you're a perfusionist, let's say you have 3 perfusionists in your program, and you don't have CRRT or access to it, what would be some of the big hurdles that you would expect to run into? What's maybe the cost of the machines, or in your experience, just how would they start?
Question. That's a great question. Okay, so one of the things that's hugely problematic for CRRT is that it's expensive.
Yeah.
Okay, but dialysis isn't cheap. Okay, the cost of dialysis is not in the cost of the disposables and the solution that's used, the dialysate. The cost is in the dialysis nurse, that has to sit there and run it for 4 hours or so. That's where the real cost is. 2 hours, 4 hours, 6 hours, whatever it ends up being. It's an extended dialysis. CRRT, the cost of the disposables and the fluids are more expensive, but the nurse at the bedside technically is able to operate it. So you take that nurse out of the equation. In terms of overall cost to the patient's hospital stay, it's really not that expensive if done properly. But if you do anything improperly, or poor patient selection, or bad access, and you just don't do it well, you don't do it the way it's intended to be used and do it well, the cost is going to be higher. So, and it's not going to benefit the patient. You want it to benefit the patient. I wanted to get back to some point that I made about the studies not detecting a difference. Let me tell you what's so hard about doing a study on CRRT. And I can't remember the name of the study. It might have been a renal trial. I'm not sure which one it was, but and you'll have to forgive me for that. But the patients were randomized. So if you met the criteria of acute renal failure, you got randomized into the CRRT group, or you got randomized into the intermittent dialysis group. If you were hemodynamically unstable, in other words, they put you on dialysis and you crumped, you were taken off of dialysis, put on CRRT, and then transitioned back to dialysis, and you were considered as part of the dialysis arm. Now, how does that make any sense?
Yeah.
So if you're a patient, pick the name of a heart surgeon. You pick the name of any heart surgeon you want, and your patient.
Dr. Robinson.
There, Dr. Robinson. Okay, and we're going to have Patrick pick Dr. Matoyer. If you go into the ICU and you're doing a study, and Dr. Robinson and Dr. Matoyer's patients are both hemodynamically unstable and need to be dialyzed, and you tell them, hey, great news, doc, your patient's going to get in the study, but they've been randomized to intermittent dialysis, knowing what we know about intermittent dialysis in terms of its increased risk of hemodynamic instability, and what we know about CRRT, which because it's slower and continuous, it's less harsh, and you don't have that hemodynamic. It actually stabilizes hemodynamics. What's Dr. Robinson and Dr. Matoyer going to tell you?
Sure, on CRRT, right?
Right. Yeah, you're randomized to intermittent dialysis. No, you're not going to do that to my patient. Put them on the CRRT. So, don't go crazy. You're going to put them on intermittent dialysis and potentially make them arrest.
Yeah.
There's no way that's going to happen. So doing these studies is very, very, very hard. And it reminds me of a comment that was made. And somebody else taught me this, and I need to make sure that I've got to remember who tells me these sayings, because it's a great saying. And it was regarding CRRT. And somebody said, well, there's no evidence to support that it increases or improves survival in this group of patients with acute renal failure. Well, his response to that was, absence of evidence is not evidence of absence. So just because a study hasn't shown it to be doesn't mean that it isn't.
Yeah.
It's never been shown not to be. It just hasn't been shown to be. And I think the reason for that is designing the studies to actually prove one way or the other is nearly impossible to do. That's what I think. Sarah, you agree with me?
Yes.
100%. Okay, you get 2 cups. Sarah, you get 2.
And I get no cup.
You get 2 cups. You get Patrick's cup. All right. Well, I think we've had a lively discussion. I think it's been a good program.
Are we done already?
I think so.
Oh,
Do you have something to add?
Well, I want to.
Well, come on,
yeah.
go.
Could you talk about the differences of citrate and heparin? I mean, I know you kind of touched on that a little bit, but just
Okay, so
just
the
go over that
differences
just in a
between
nutshell.
citrate and heparin
Yeah.
are.
I mean, I know the differences of the drugs.
Sure.
But you know what I mean.
Yeah, I know. So if you give heparin, I know what you're asking me. If you give heparin, you're giving it systemically.
Sure.
Okay. And you can reverse it, but you basically are going to anticoagulate the patient. And that's going to help your CRRT machine not clot because it's thrombogenic. If you give citrate, the citrate goes into the access line,
Right.
decalcifies the blood,
Yep.
gets returned to the patient simultaneously to calcium going into the patient at the rate previously shown and prescribed so that you keep your ionized calcium levels of the patient normal. So the patient's calcium level never changes.
Yeah. And that's off label?
Yeah, it's off label.
Wow.
Not FDA.
I've seen it done. Yeah.
It's off label, yeah. Seen it done, but that's the difference. And you do have to be concerned a little bit in that I think the citrate can cause, you've got to be careful. You got to know what you're doing. If you end up not giving the calcium back, well, then your patient's going to crump because they're going to become grossly hypocalcemic. That's a problem. I told you that you can't not give it where it'll recirc back to the machine, except in the case with Sarah's, which was unique and different, and it worked in that particular circumstance. And you darn sure don't want to give it in a peripheral line and have it infiltrate because they're going to lose an arm. So there's some problems with it. It's not nearly as easy as heparin, but if you have a patient who is acute renal failure and they need to be on dialysis to survive, and they're a HITS patient, they have a heparin antibody, and you can't give them heparin. I guess you could give them argatroban, but I think that regionally anticoagulating the CRRT circuit to me makes way more sense.
Yeah. Okay.
Or they're bleeding. Let's say you have a bleeding patient. Let's not use a HITS patient. Let's use a patient who is bleeding, has surgical bleeding, and you don't want to anticoagulate the patient. So even argatroban would be a horrible idea. Regional anticoagulation of the system without any systemic effect makes a lot of sense. Now they will get a little more alkalotic, metabolically alkalotic, but you can treat that, so that's not too hard. You can change one of the bags on the machine from the prismasate solution or Braun, whatever solution it is you're using. I say prismasate, but whatever bicarb-based solution, and you can add one bag of saline, for example, normal saline, which will dilute that bicarb down. So you can correct it fairly easily. It's not that hard to do. And that's the thing about these machines is you can change the fluids and mix and match them to accomplish what you want the plasma water to look like. It's really pretty cool. I mean, I think, like I said, I'd use the resources. There's no way I can tell you everything there is to know about CRRT in this short of a program. It's a really neat, but somewhat complex. It's simple and complex. It's kind of a dichotomy. It just seems like so simple, but there's a lot of nuance to it. That you have to learn. And I think, again, not to belabor the message or to pound my point, with a hammer, I think perfusionists need to be more engaged with these kinds of odd modalities we normally don't get involved in, not necessarily because we should be absorbing them or taking them over, but because we need to think out. It's basically thinking outside of your box. And the other guy's tool chest may have a tool in it that just might work for us, but we're so siloed, we only look in our own toolbox. We need to start thinking about other people's toolboxes. Even in dissimilar industries, this is similar, but dissimilar industries as well. It's the whole concept of that pumps and pipes thing that I think is, Sarah, if anybody watching, that Pumps and Pipes conference is incredible. It blends cardiovascular medicine, aerospace, and the oil and gas industry together. And that's why it's called
Heard of
Pumps
that.
and Pipes.
Yeah.
And it's an incredible, but the conference with some neat people and stuff you'll never hear anywhere else. And that's their whole theme is the other guy's tool chest. You have three dissimilar industries, and yet so much of what each of them do actually cross over into each other, and they've all been able to learn from each other. And I think that that's what we need to do too. Work more with nephrology, even though some nephrologists are 100% opposed to CRRT, others embrace it. Some intensivists really believe in it, some do not. Cardiovascular surgeons should be the ones ordering it on their patients when they're unstable and they start becoming, oliguric or they're even just their urine output's going down and they see a problem is starting to occur, ordering it, demanding that they have it, because it's so much better for our patients than waiting until we have to do intermittent dialysis.
Yeah.
And ECMO patients, I think every ECMO patient should have CRRT hooked up to them, period. Now, Chris Loosby disagrees with me on that. We're going to discuss that on Thursday as well. So, Sarah, I might need your backup, because Chris Loosby, who's going to be sitting over here in this chair on Thursday, he completely disagrees with me that CRRT should be used on ECMO patients. I'm not sure why. I'm going to wait to see what he has to say and his reason for it, but I completely disagree with him. So that should be a real lively debate between him and I as well. Did you have any other questions?
I would like to plug a show coming up on the 4th.
Sure, plug
I
your
have
show.
to do this because
Plug your show.
we are going to do something that has never been done before. And it may sound very basic, but on October 4th, I know it's a ways off, and it'll be on the website and all. As a perfusionist, if somebody else is running the pump, you can go and look at the heart and you can see what's happening there during the surgery. Or if you're running the pump, you can see what's happening with the pump and you can look up at the vitals and you can, see what effect you have on that. But you can't see all three at once. There's no way to do it at all. So what we're doing, and we've been working on this for probably 4 months, I would say, getting footage. We've got a camera trained on the reservoir and on the pump head. And we've got a camera trained on each of the pump heads, the suckers and the vents and the LV vent if we're using that. A camera on the heart and also a live feed from the vitals. So every single, and all of this is streamed into one box, which is then we can show this in boxes on the screen. And we're gonna have this video, which we'll have edited down to, we don't know how long the video will be, but you'll be able to see exactly what happens when the perfusionist makes a change on the circuit or when the surgeon makes a change up on the field. And I think there's going to be a lot to be learned both from surgeons and from perfusionists. We're going to have a couple of surgeons here, at least one, maybe two, who were part of the filming, so they'll be here to make comments. Maybe some of them will learn that when they tell us to turn the sump up, that it doesn't really make any difference in the blood in the coronaries. We'll be able to see that, so we'll see. And maybe we'll learn something too.
That is going to be a really, 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 really good program. And I think what the surgeons are that are going to come and participate, and even those watching it are going to learn that just because they told us to do something and because we said we were going to, that we may not actually do it.
Oh, I hope they don't see that.
That's good too. All right. So they say flow down. Yeah, flows down. Yeah, they'll see that too. So, all right. Well, listen, I'm gonna, I think, call it early. I think we've had a great discussion. Sarah, thank you so much for contributing the way you did.